Welcome back, or welcome if this is your first time visiting us on cable TV or YouTube. My name's Tina Hurley. I'm the founder and executive director of a charity, Less Leg More Heart. We help people in the community with disabilities in 4 ways: peer mentorship, medical advocacy, we fund holistic approaches to care, and we fund services in the home during transition. Today I have a really exciting guest, someone that is a personal friend and is also helping me on my journey, but has information and tools that I really wanted to share with you because I think it's life-changing. So without further ado, Kyle, thank you for being here today.
Yeah, no problem.
I think the coolest place to start is you're a doctor of physical therapy.
Budding.
Yeah, yes. Budding. I think you're bloomed. To me, you're bloomed. But that you weren't always. You're a new, physical therapy doctor, and before you were a gym owner.
Yep.
And our paths crossed in CrossFit, and there's this really beautiful path that now got us to this place where we're managing or talking about the management aspects of conservative care and the importance of that with things that, in a community that really does prefer, in a lot of senses, surgeries. And so only by way of me having poor outcomes with my surgeries was it something that was luring, this idea of conservative care. And now in the headway that I've been making in my journey, because of some implementations of tactics that you've shared with me, I can't help but want to stand on the top of a mountain and just, scream this to people. So can you share with them a little bit about how we met and how we ended up being back here?
Sure, like the original one?
Yeah.
So I met Tina back when I was running CrossFit 207 in Sanford. I don't run it anymore. I went to PT school. And while we were there, we hosted a competition, and I'd also bumped into her once or twice at some competitions down at Ever-Proven CrossFit in Portsmouth, New Hampshire.
I think it's like Dover, yeah, but close.
Is it Dover?
Yeah, it's
yeah.
New Hampshire.
My New Hampshire geography is not that good.
Portsmouth's like moving out toward Dover. Like it's all, the city's growing
It's towards
inward.
the coast from the middle of nowhere where I am.
Exactly.
And one of the competitions we held in-house, we tended to do some pretty fun in-house competitions. We'd usually push our athletes pretty hard. We'd try to squeeze a lot into a day, and we'd try to ask modalities that weren't very typical. We had good turnover during the competition, so I'm assuming that's part of what attracted you to what we did. And you're the only adaptive athlete that signed up for it. And we pretty much kind of custom tailored the events to match where you were.
And the backstory too, just to fill in some of those blanks, is I was an athlete at Ever-Proven, and one of the owners wanted to do that competition and needed a partner, and just didn't mind that I had one leg.
Yeah, did you have Matt?
It was actually Christian.
You had Christian on there too.
But yeah, and he didn't. He was just like, oh, I need a female partner, and I think it'd be cool to have you come. And so it wasn't an adaptive competition, and it was my birthday month, and so I was looking for something to chase, endorphins for. And so we had signed up. I had no idea about your gym or you or the way that you were going to approach it. I had no idea that you would even have said yes, because it was not an adaptive athlete, event. It was something that was for able bodies, and only because I'm a little bit, thrill-seeking, that I would have even signed up for it. But I didn't realize you were going to go through the lengths that you went through to make it as accommodating and as fair as you did across the board. Talk a little bit about what you did.
Yeah, so I really enjoyed scaling CrossFit workouts either up or down, and I got a good feel for it where I could usually match it to some sort of percentile, and I figured this is something similar. It's just, okay, you're going to use your left lower extremity a little bit less. So let's see how that all feels. So we tried doing different standards for squatting the boxes, seeing what was comparable calories on the assault bike. I think on that one, we just said, have at it. You got to do a calorie to calorie.
Yeah.
How the pull-up transitions worked and all that. And basically just said, hey, this is on par. Metabolically, you're going to be just as challenged. You aren't going to be able to just blow through reps any faster than anybody else. And basically, it's just who can fight off fatigue the best in these different modalities. Mm-hmm. And it made for a really good competition.
Well, you even measured out, though. You got on your knees for the kettlebell swings I was doing for my knees. And you stood and tried weights, and then you knelt and you tried weights, and you figured the one out that felt the same to you as an able-bodied in both of those positions, which is pretty neat. So I wasn't at a standard or a prescription RX weight for a female. It was what was appropriate based on what you thought was the same level of stimulus.
Well, and it's one of those things where when you're looking at like functional movements, core to extremity motions, if you get rid of the ability to like run the kinetic chain all the way into the ground, it's a lot tougher to get some speed on a kettlebell
Totally.
or to be able to throw a wall ball as high. So you kind of just go, okay, this is what 30 reps feels like. This is how tired I am when I'm going to the bike. So now if I'm in this position, what gets me to a similar point?
Well, I was so appreciative that you had done all that. And it was just icing on the cake that my team, I think we came in 4th out of 12 teams.
I honestly, I've done so many. It's fuzzy for me. It's probably
you don't
sticks better
remember
for
from 5 years ago?
I
Yeah, so we were 4th, and the last workout was the top 3 teams to make. That's usually the 4th workout.
Yeah.
We just missed that cutoff, and I remember sitting back going, "I'm glad I'm not doing a 4th workout, but I'm so lucky. Like I feel so grateful that I was able to get so close to that top because the person that ran this gym had the wherewithal to say yes to like the opportunity for this different experience for this person." And then go out of your way to figure out what was going to make it work. Not think about the problem, but think about the solution behind the problem to make it fair for everybody.
Right.
And nobody had a problem with it. So when I'm talking, because we talk to this audience all the time, if you're somebody that's in a position that is brought in front of you that there's an adaptive person or somebody that has a physical impairment, if you can proceed not with fear first, but with figuring it out as your primary goal and by maintaining an open mindset, I really think that you can improve the quality of lives of the folks around you and also improve your circumstances and your experiences, because what Kyle did really, that was the first CrossFit competition that I had done as a person after my amputation. It brought me tremendous joy. It returned me to my home in the gym that I had been missing for so many years. It gave me back community and physicality and made me feel my sense of power. I felt supported and nurtured and safe in that environment because of the constructs that he had put up. And all of that transcended well beyond that one couple hour competition. That really did springboard my confidence to start taking up adaptive CrossFit and then go on to win the Adaptive CrossFit Champions as a female in 2018. So it was kind of like the catalyst for all of that. So
cool.
By making a small, ethically minded decision, which is what you did, you're a person that has a certain caliber of ethics, and that was just what was appropriate for you. But what could have happened was that I would have been denied that opportunity. Yep. And oftentimes that does happen for people. So thank you so much for going out of your way and doing that.
Yeah, no problem.
So then I didn't hear from you for 4 years.
Yeah.
So then, because you live in Maine and I'm in New Hampshire and our lives are separate, we don't really know each other that closely. Yep. And I had shared with you at the competition, you'd asked about my condition, and I had shared that I had popliteal entrapment and the kind of, I don't even remember all the details of what I shared with you, but apparently it left some kind of a seed there.
Yeah. Basically, when we'd first talked, we were kind of going over how many procedures had been done, what were the outcomes for different procedures. And basically, one of the things that we'd kind of landed on is we were using the phrase anatomical or physiological problem at the time. And we were both kind of like, yeah, you figure if it'd be anatomical, it would have been like, like you just go in, you do your mechanics, and then you're out, and then it's fixed. But because the outcomes seem to be either increasingly negative or a little all over the place, you and I both kind of reached the same conclusion, like there must be something else going on here that isn't just anatomical or structural. So as I transitioned into PT school, I kind of just kept that in mind anytime I looked at that part of the body, interested in how knees lock and unlock. Turns out there's a lot more motion in knee than what you'd suspect. And it turns out knees also are pretty powerless compared to the foot below them or the hip above them. So as I went through it, just noticed there wasn't a lot of talk about the syndrome. I had only seen one article on it. It was just about imaging for it. It wasn't really about how to treat it. And so as the PT school kind of wound down and I thought I had a little bit more free time, I just started doing more reading on my own, trying to reach, the conclusions that I wanted to reach just by looking at a lot of primary resources and anatomy. Same way that I'd solved a lot of stuff for when it came to weightlifting, basic gymnastics, how to run a business, all that other stuff. Like autodidactic is like a fun thing to do. Mm-hmm. And then I was like, okay, let's read a review. And while I was going through the review, I was like, holy cow, okay. So everything that we had suspected and talked about in the conversation makes sense when we look at this review. That's fantastic. I'd love to reach out to her. Like, I knew that you were running a charity. Matt had always talked very highly of you. And so I was like, let's see what she's up to nowadays. Like, I'm interested in this because right now, like, it's been the same story in my head for a long time. despite all the different research on it, I'm still coming to like a similar point. Let's see where she's at right now.
So I'm literally at, when I got this text, this is only like a couple months ago.
Yeah.
And I'm a single mom, disabled single mom. I am in the middle of getting all these tests on my legs. They're looking at getting, osseointegration on this leg, and everybody's focusing on wanting to cut into this leg. They've been wanting to surgically operate for 3 years. And like, I just let go of the hope that I wasn't going to have all these surgeries, including amputation of my right leg, which is what things are slated to be. And, I was kind of like, okay, I can walk 8 to 12 minutes at a time, and I have to stop, in the grocery store and the all the department stores, and I carry a, stool in my stroller because I have to stop so frequently because I don't have blood flow. But that's just life, and that's what it's going to be. That's my new normal. So why fight it, right? I have to embrace it. But now this, I'm so muddling through this everyday like grind and running this charity that gives me a dose of perspective about everybody's suffering in the world and really doesn't allow me to unpack at the pity cabin very often, which I'm blessed to have. And I get this random text in the middle of my day, changing diapers, that said, "Hey, Tina, I don't know if you remember me. This is Kyle from 207. I can quote this because I kept going back to it like, what? This is Kyle from 207. I don't know if you remember me, but I just graduated from physical therapy school, and I have some ideas about entrapment if you'd like to get together." And that's probably it, right? Exactly, verbatim.
I was at the soup shack.
Yeah, I look at this and I'm like, what? Just how out of left field, at what an impressively amazing time to get this message. People that are faithful would say this is a God wink, they call it. People that believe in universal energy would say that it was universal energy. People that just believe in good karma would say some of your goodness is coming back to you. Whatever it was, I'm like, oh gosh, this gives me a little bit of hope again that somebody can help me, because you get beaten down in the medical system, and I'm speaking as a medical clinician, because there's only so many needles and narcotics and surgeries you can do before the life force is depleted, and you just want to focus on quality of life at the expense of sometimes what's in your best interest medically, because what's in your best interest medically or from the medical Western model is not what's in the best interest of you financially, emotionally, socially, which those are 3 out of 4, right? The other one is medically. Yeah. Those are 3 of 4 of like the spheres of your life. And so once you've had negative outcomes, 13 surgeries resulting in amputation, you have to step back and go, all right, I'm outside the snow globe, and what's important to me is not to pay tens of thousands of dollars in bills, to make sure that my son can grow up in a comfortable world, to run this charity to help these people. It's not really about saving my foot or being comfortable anymore, and that's okay. My legacy is bigger than me. And then you came in, you sent that message, and I'm like, okay, at worst case scenario, I get a little bit of false hope, and I get the opportunity to powwow with someone that I really respect from a cerebral standpoint and reconnect with, and maybe learn some things, positive or negative. And best case scenario, we could save my foot. Like, that's a big jump, right? But, that is the polar end of the opportunity. And if it falls in the middle, that's still really great.
Yeah.
So, of course, I wrote back and I'm like, let's do this. And our first time together, I think you spent, like hours we were talking, and like we're just playing with ideas. And I want you to kind of explain where we went with it.
Yeah, so that first day we ended up hooking up. It was kind of over a lunch, and we were just chit-chatting, like, what were your routines and habits? What was your gymnastics history like? What'd you do after gymnastics? What was your ankle injuries like? How does your hips feel, lower back feel? We watched you walk a little bit. And then I kind of just said, okay, I think I have a good idea. I'll write down a paper. The big thing for me that kind of followed some, like a personal red flag, was I kept thinking in my head, what if she says that she went right from gymnastics practice right into high heels? Like, that for me is like, okay, we have to look into this, because the biomechanics on that are like really, really interesting. Gymnasts have their whole set of heel cord issues. They plague people for a long time, whether it's you're looking at just tendon pain, or a big thing in CrossFit was if gymnasts went into CrossFit, they always had to be careful on rebounding box jumps because their heel cords are tight. They make noises. So when you said that was part of your normal habit, I was like, well, okay, either I'm a really good guesser, or, this is following some sort of logic. And so...
Well, then I told you about the pump bump.
Yep, we have the off-axis pulling that may be coming from there. So then I was like, I'll just write an argument on a piece of paper, and then we'll start just seeing what things work well, what things don't. Is it just no one's thought of this for any PT that you've been to in the past? And
it's complicated, right? It's like this is a very dynamic, complicated, long-standing, multifaceted, interdepartment issue.
Yes.
And so that's the challenge is when you pick up my chart, Mr. Pro bono, good-hearted, passionate person that's doing this because of the kindness of his own heart, that chart is this big.
Yeah.
And so a lot of people that don't have the same interest, passion as a budding or bloomed, in my opinion, PT, that have the need for reimbursement and have the fast medical model of I get to see you for 30 minutes 3 times a week, or there are so many barriers to people not necessarily having the passion for wanting to go into that, but also the time.
Yeah.
And that's the difference here.
And I think that's been one of the fun things to play around with is like for this, just because there's been like no rules, it's just kind of like just playing around, see what works. We've been able to see like what duration works better for like getting into a trigger point or not. We get to see what produces well for like improving gait. We can spend more time looking at accessory motions. Usually when you're dealing with people that come in and out, you're looking at horses, not zebras. But needless to say, this is kind of a zebra situation because you're like, an atraumatic amputation, how's that work? And it's not like your typical like cancer or anything like that. It's just, you just started losing circulation. Well, that sounds weird. That sounds like a zebra. Medical systems are made to work with horses. They're made to put people through quickly. It's hard to find niches for zebras because not all the zebras are in one place. They're spread out over the pastures. Do they have pastures where zebras are? What do you call
Sahara,
that?
What do you call that?
I have no idea.
I don't know. Those areas, pasture.
Yeah.
I mean, pasture seems more like a field. I feel like we should just say like Sahara or the what's.
They have to eat grass, I think.
Yeah.
So. It's basically been kind of neat finding someone that you're in the medical profession, you understand this thing inside of out, you've explored it, you have a good athletic background. I've had my own experience with some gymnastics and Taekwondo, which is similar for lower extremity biomechanics. I've worked my own issues as someone that's done athletics and transitioned well in some areas and transitioned poorly in others. I just feel like what's happened is there's been just an opportunity and we've capitalized upon it where you get people that are speaking the same language, have the same kind of ambition, the same kind of openness, and you get to problem solve in a different way when you're taking away a lot of the barriers and constraints versus the 30 minutes inside of a clinic, having to make sure it's billable under a certain study, make sure that this is going to get reimbursed in this way and that you can turn people over. All the things that kind of are preoccupied a person's head about keeping the lights on and the doors open. So that's been a really cool way to fill the gap and transition from student to going into the profession. And it's been really good for improving my manual therapy a lot because my last clinical, you don't do any of that when you're working in a skilled nursing facility.
Yeah, there is such a deficit in training. I mean, as a PA, I can speak to that as well, right? You get out in the real world and there's so many challenges perhaps with either the curriculum or the construct of the profession or, these pieces that, you can't fix the system, but if we're individuals in the system, we can construct our own system to try to impact the change that we're looking to do. And you've certainly done that in my life through this kind of like alternative, informal model of like what sort of we've been doing on the side. And so as you develop that into your own practice and moving forward, the idea is exciting because you can share with people what's worked, which is multiple hour therapy sessions.
Yeah.
I mean, you need time to get into these myofascial areas. And that's something that's been impressive for me, for you, is the stamina and the physicality that's required to do a good treatment dose of manual therapy. I mean, it's significant. And I don't know that everybody could do it.
And I think that's been something that I've learned lately too. Like I've been very comfortable inside of clinics, like handling people. I'd wrestled in the past, did jiu-jitsu in the past. So you're like good with putting your hands on people. But being able to just continually play with mechanics, it seems like, well, there's this warm-up window, which you can't even hit that inside of certain windows. And there are clinicians that are out there that are great at manual therapy that can probably hit these windows better than I can in certain ways. But given that, okay, former level 10 gymnast, you would work out for hours and hours on end, you're still conditioned, you're doing all this stuff. How guarded can the superficial tissue be? Well, it turns out pretty guarded. We're learning that it takes a while to be able to get towards a trigger point. And once you're on a trigger point, Because
when you say guarded, though, for folks, because I understand, because you've been enlightening me, during our sessions, but guarded in the sense of what for the viewers?
So just think about anything that makes you uncomfortable and just feel how like you kind of tense up. Or like, let's say you watch an MMA fight and you've done martial arts, like you kind of just go through a little bit of like subliminal motion and like tension. Like you'll be on the edge of your seat is the way that you describe it for like movies. But that's like a phenomena that it shows up in a lot of different ways. Like we're made to carry tone here. You're made to use this sort of extensor reflex to sit up. People have posture. Posture is upregulated tissue or downregulated tissue, and where does that put you in space? Sometimes apparently things can go a little bit awry and you can carry a bunch of tension on one side, a bunch of tension on the other. The system says it's balanced like a seesaw, but I mean that seesaw is getting stressed.
Right.
Like if it's made to carry a kid on each end, but I put a sumo wrestler on each end, that's not good for the seesaw. How many times can we use this before it breaks? And kind of playing that into, okay, let's look at what might be guarded here. That tells you a lot, especially if you can kind of unwind some of the gymnastics mechanics that we were looking into and those really ballistic motions where you have to be strong the age you're learning them and progressing.
As people are listening to you talk, I bet they're at home on their couch or on the computer going, wow, she's lucky. Like, can you hear the things that he's saying and the fact that he has gymnastics background and he's willing to think about not just the things I'm telling him and presenting like, but also the mechanics of the muscle memory that have been in place for decades and how to overwrite that through manual therapy and exercise moving forward. Like we've discussed and we've done home exercise program things and stimulation. I mean, the treatment modality is multifaceted. Yeah. There's what you do to crank during the sessions, but then you're also saying, I need you to do this, this, and this to be able to move this way and that way, and also stimulate your feet intrinsics to help with this motion and abduction because that's going to upchain this. I mean, it's literally like such a complicated, beautiful explanation of this conservative care in a holistic way that I wish everybody had access to, right? I wish that everybody could find a Kyle. Like if there are people out there that have challenges moving, right? That's really the only inclusion criteria. I have pain or challenges moving that would put them in a place of need for somebody that is a doctor of physical therapy, but not just a DPT, because not all DPTs are thinking in this kind of way. It's almost like an independent
It's
DPT
a very diverse field.
Yeah.
I'm realizing
how do they find you? Or like, how do they find people like you? I mean, I know that eventually you're going to go on to teach other doctor of physical therapies is a goal of yours, because spreading this type of, it's an approach that needs to be taught.
Yeah. So for this condition that we're kind of working around, like the paper that, like the rough draft we're working on is like really dense. So besides that, you can find specialists in PT, and they're listed on, I think you go to the APTA website, they have the different specialties, like you have people that specialize in neurology, people that specialize in orthopedics, but kind of where we're looking at is all the in-betweens. So we're looking at, okay, we're gonna look at a little bit more like neuromuscular, we're gonna pull in a little bit more psychology. That for me has been one of the things that has really helped me when I was working in my clinicals, and I'm gonna try to use it when I go forward, is a lot of the psychology that goes into play when you're doing motion or when you're dealing with pain or anything else like that. Our brain was basically made to navigate the environment. That's it. PTs work on the part that does motion, but that still involves a brain. So what are some of the weird quirks that can come out that we wouldn't directly notice? What are the things that don't translate well from a textbook to real life? Mm-hmm. What are the things that you've seen in real life first? And then when you read the textbook, you go, oh, that's what this is. That stuff gets missed a lot, I think, when you're looking at usual professional progressions. When you look at risk-taking behaviors, too, from a professional standpoint, a lot of people work really, really hard to work towards degrees. And they've done that in ways of following certain paper trails, but there are gaps in literature. I'd ask questions of my professors frequently. They'd be like, no, there's a gap in literature here. And then I would just go and find the field that seems to have explored it the most. Okay, that's over in this entire profession. Doesn't mean it doesn't translate. Mm-hmm. It just means that you got to learn how to speak the other lingo and get comfortable with that. And that's been a big influential factor when we're looking at this is, okay, what are all the mechanics I remember from doing CrossFit and all the weightlifting and everything else that goes with it? How does that play into this? Okay, there's a couple things that aren't jiving well mechanically with that. Okay, well, let's look at the PT stuff. Okay, let's look at everything that could be neuromuscular. Let's look at some of the new fields inside of PT, like if we're looking at neural tensioning, and then we kind of drag that over to something like vascular tensioning. Does that exist? I have no idea. It sounds fake, it sounds made up. I think we kind of have made that up to some extent, but it seems to be guiding some of the stuff we're playing with pretty well.
Yeah.
So I can't really make like definitive claims, I guess, about one way or the other. Then I'm getting really good practice. I'm very happy with how happy you are with the outcomes.
I'm able to get through a grocery store. I mean, those small improvements for anybody that has a physical impairment will say it's so profound. Something as small as you saying, you know, you always lean laterally and it's creating an up chain effect from your foot. Every time you're standing, see where you're at. Are you pushing back and out? If so, plant your big toe and ground your foot in this way and then relax at the ankle. And it's exactly what I was doing. And so I was actually creating heightened states of tension because of my body's imbalances between what's tensioning, what's stretched, what's tight, and what can activate, because everything's so atrophied from all of the surgeries that only the things that can fire are firing, and they're firing more and harder while the other things just stay dormant. And so waking things up, and part of that waking up is an awakening for myself, and the feedback, the biofeedback that I need to constantly be doing to check in with myself proprioceptively to see what I'm doing that is exacerbating the issue. And I think that's a huge piece that people don't realize, is that we are so trainable.
Yeah.
Even pathologic chronic conditions that need surgery came about because of certain maladaptations and misalignments that really do need to be addressed long-term, whether you have the surgery or not, because something else is just going to happen. Something upchain or around that area is going to take the stress of that area that you just replaced and now is an artificial joint, and it's just going to cascade effect. And there's so many examples of people that we know in the community, loved ones, friends, that have this. They have an ankle surgery, and then all of a sudden they're getting a knee surgery, and then they're having a hip surgery, and now their back's off. And you're just chasing this moving target because you're never actually treating the state of what's dysfunctional. You're treating the outcomes of what's dysfunctional. And that's something that you've really opened my eyes to, and that I wish more people could approach this like.
Yep. I think part of it is it's tough to quantify certain things, especially when there's something that's qualitative. There's lots of questionnaires and stuff that people try to do it, but at the end of the day, it's, are you a happy customer and you'd want to come back, or are you a disgruntled customer and you'd want to go away? There's certain decisions where you don't get to check either of those boxes. You're either fully committed or you're not. There's a lot to be said about how plastic people are. There's a lot that happens with people that we don't notice. There's a lot of habit change that we don't notice. There's mechanical changes that we don't notice until it's gone far enough along that if someone mentions, you go, oh wow, I do have that mannerism. That's strange. When did that show up? And you can think back, you can never really find the beginning of it, but you might be able to find somewhere in the middle where, oh yeah, no, I had that habit for a while, didn't I? And being able to kind of pick at those things is really helpful. One of the things that helps for that is you get the medical training. So like I can just say a word that I don't have to break down or change.
I don't know. You say a lot of words that I need you to clarify sometimes. Your vocabulary is outside of mine, and that's pretty impressive.
And then the other part is just there's a lot of overlap though.
Yeah.
So I find a lot of things relatable where it's like, oh man, I had this injury one time and rehabbing from that was this type of stuff, and I couldn't figure out for 6 months, and then I found it and it was great. Well, now I get to tell you that in 2 seconds right now.
It's wonderful. Now I am so excited to be able to geek out with you. And for those that are on cable, our session is over, but those that are, come over to our YouTube, because now we're going to break the table out and we're going to show you some things that we've been talking about, have Kyle work on me and kind of talk through some of his techniques. So stay with us. All right, guys, Kyle was kind enough to bring his table today so that we could demonstrate some of the techniques that we've been using and talk through some of the nerdy pieces that we really like to get into. So without further ado, I'm going to get down and get a treatment.
Okay. So I'll introduce like a couple of the premises that we're looking at when we're looking at her leg. So one of the things to know about knees is that they twist. And whenever you think of a twisted knee, you usually think, oh, I injured my knee. But they naturally twist as they go into extension. So if her leg goes straight, I expect that her upper thigh is going to spin in and her shin is going to spin out. That's when you're standing there, they say, don't lock your knees, you might pass out. So with that in mind, when we started talking early on about some habits, past athletic history, things like that, looking at how you walked, we pretty much went under the idea that, okay, if your blood vessel is inside your leg, when your leg moves, your blood vessel moves. So, okay, what type of funny mechanics would then have a weird effect on your blood vessel? So there's a thing called neural tension that as the nerve comes down through its tunnel, if you pin it at a part of the tunnel, it's going to change the way it threads through, right? You basically make a traffic jam. And in some people, this can cause issues. Some people get it as carpal tunnel, like a common form of like neural tension that people test for. It gets trapped right here, you get nerve problems. Nerves and blood vessels follow a lot of the same paths. So with that in mind, we were thinking, okay, there's all these funny biomechanical things that are going on from gymnastics and all the habituation that goes on there. We see that you walk with a certain type of gait that looks not optimal. So let's pretend that this is the blood vessel inside of her leg. So if I had this blood vessel right here and there's not a lot of tension in it, not a lot's going on. If I dunk this in water and I wanted to bring it out, this isn't a good position to do it. But if I bring my hands really close together, I can suddenly get a lot of torque on that piece of tissue. So what could happen inside of a leg that would do that? And so this is like one of those funny harebrained theses, but so far we've been able to work around it and it's led us down some pretty cool paths. What could make my hands go closer together on her leg and then twist on a vessel and get something called adventitial thickening? So part of it would be there's a tunnel right above it, the adductor canal, and then there's a tunnel down below it in our tarsal tunnel. And whenever our heel bone is tilted in or out, so if I tilt my heel this way and it goes past neutral, I get extra pressure in the tunnel. If I go in, I get extra pressure in the tunnel. And so you might not be able to see it well from there, but her foot's always kinked in a little bit. This is a lot better than when we first started too. Like everything's much more relaxed. So we started looking at that. We started looking at how the knee was set up. Where was the tension in it? When we first started working, this medial headed gastroc was rock hard and the lateral compartment was like very, very pressurized. Like you could not push on it without feeling like you're pushing into just something that felt a little overinflated. One of the more recent reviews on Popliteal Entrapment talks about that medial head of the gastroc having a huge influence upon it.
So what's interesting too is they took it out during one of my surgeries on the left side, and it didn't completely remove the issue, likely like you mentioned, because of all of the other compensatory changes that were creating the functional issue. Yeah,
and you might even run into like some like blood flow paradoxes too, because everybody kind of has similar vasculature problems, but something that's really common is we're all born. So when a baby's in development, most of the blood flow is shunted towards the head. So they get a really big head. There's some other funny things that happen with blood flow, like it's a little bit more direct towards one half of the head. So you'll get a little bit larger left hemiface than the right hemiface typically. Where blood flow goes, that affects what grows. When we're looking at here, you could say, okay, if I block the blood flow here, there's going to be stuff that comes around it and gets to the more proximal tissue, but I just can't get all the way downstream. Okay, so this stuff's going to get stronger and stronger and stronger, and this stuff's going to get weaker and weaker and weaker. And one of the ways that we can compensate for something getting weaker is we can get rigid, and we can also, when we're weak, we can't move our toes. So when Tina first started doing a bunch of this stuff, there wasn't as much grip strength in the toes. And now she can do like these flares and all this other stuff that I can't do. Her feet were like mine the first day we worked, and like my feet have no dexterity. So we started looking at a lot of those foot intrinsics that might not have been strong. And then we started looking at how her ankle comes up in the dorsiflexion, because that's something that gymnasts just
But it's so much better now compared,
some of the ways that you can work on that too is just the joint can get a little bit gummed up. It needs to have space to move into itself. So just giving a little bit of extra pressure through it and working through some manual therapy skills there has really helped out. But while we're doing that, if you want to come down the table just a touch that we were hanging off, some of the stuff that we really started to look at, because Level 10 gymnast, how long were you working out in the gym at a time?
Oh man, half days.
Half days. So more than an hour, right?
Yeah.
So one of the things that happens with that is you have to learn to get really energy efficient. And one of the ways that your body will try to get energy efficient is it will try to use elasticity. We lay down collagen everywhere in all sorts of directions. And one of the ways that we'll do it is even between our skin and the muscle. So if we look at her soleus right here, back of the calf, whatever we want to call it, some of this tissue right here, your skin should be able to pull off your muscle pretty good and not have an issue. So like if I look at the back of her hand and I try to grab any of the skin there, see how that's an easy grab? But we get here, you can't quite pull it away. So that means that the skin may be adhered to the tissue underneath. So we're like, okay, let's play with some of that. So while we're doing a lot of these basic skills and drills, like trying to do a little bit of a glide on the joint to free it up, we'll start doing a lot of skin drags, and then we'll pin the joint into its end range of motion where it feels pretty good.
Feels so relieving.
And basically, as you start to pull down the skin, instead of the skin trying to pull the muscle up and everything else the muscle's connected to near or around, we just start pulling it back to where it should be able to go. So you can picture a gymnast, they do everything with pointed feet. They wear high heels after they leave too. And they got to be explosive. So you have to go 10 feet in the air and do a bunch of flips and come back down, do another vault, and just keep leaving the floor with a lot of power. Eventually what's going to happen is you're just going to get good at only that if that's what you're doing all day. You're not going to be good at standing around. You're not going to be good at walking long distance casually with energy efficiency. All your body knows is I need to vault really, really hard. So we just started looking at some of the accessory motions that might go away. So feeling through that medial head of the gastroc, that thing was just...
Yeah, cement block.
Yeah, it was in charge of the whole foot.
Yep.
So you can have the world's strongest muscle and we could strengthen up your intrinsics, but if you still have the gastroc in charge, you don't get to use the intrinsics in the foot. So we just do really, really simple skin drags, and I mean, I think you could call it myofascial. I don't know if you need to have like a check mark after your name to be able to say the word myofascia or not. But you just look for a tender point like that.
It's like a chain of command. The way I think about it too is, you know, I had such a micromanaging calf, like that medial head of the gastroc. The calf was so overpowering that it basically made everything else oppressed.
Yep.
And it's the same for, like, think about a hierarchy within a business. Like if you've got that one oppressive force, it really doesn't allow the other players of the team to express their full potentials. And in the same way, the muscles kind of, and they do that same thing, right? So everything else in my foot had sort of shut off because of this maladaptive pattern. And it was only by waking those things up, by stretching and also stimulation. I've been using that stimulant every day to wake up some of the feet muscles. I never would have started. I never would have even known to do that or start with that if you hadn't put this puzzle together in the way that you did. So it's really fascinating.
Yeah, and you don't know what you don't know.
That's right.
Things that are insidious too, like insidiousness has like a negative connotation for a reason. It's because it creeps in and you don't notice it until it has this big, horrible, profound effect. And there's some other stuff that kind of goes on with gymnast sort of postures too, where it can kind of create a perfect storm. That big anterior tilt that happens in the hip. Yep, now you're missing some of the strength that you should have up there, so you're going to make up for it somewhere else. Well, this sure seems like a really strong muscle. Let's ask them to do this heavy lifting some more. We'll stand on the shoulders of this giant.
Yeah, right.
And it just kind of compounds and compounds and compounds. And then once you've gone down that road far enough, well, how do you go back to baseline?
Right.
You can train back towards baseline, but there has to be somebody that trains people back towards baseline. And there seems to be a gap in that part of care.
Yes.
I think for a lot of this stuff too, because you're well-conditioned too, you have well-conditioned people problems. Deconditioned people problems are more common, especially here in the United States. I think it'd be different elsewhere. But if you're deconditioned, you can do a lot of stuff and it'll improve you. And basically the idea is don't do too much. But if you're really conditioned, it takes a lot to kind of loosen up tissue. It takes a lot more to fatigue tissue appropriately. It takes a lot more to override maybe domineering muscles. The only reason why I think I relate well to that is because I've also been in that boat once or twice before. So what we're trying to do here is see if we can get down to a trigger point. So did I ever explain the difference between a trigger point and tender point?
You may have, but I would love for you to cover it.
So tender points hurt. Trigger points feel different than hurt. So like if you got one in your back and I push on it and you go, ooh, that hurts right in my shoulder where you're pushing, that's a tender point. But if I push on your back and you go, wow, I feel that in my ear all the way around to my eye, that's a trigger point now.
Okay.
An easy way to think about it is essentially that tender point has been there long enough and strong enough that you've integrated it into your body schema in a funny way.
Okay.
That now you feel it in the back of your head, even though it's nowhere near connected to that. That's the best way I've come to understand a trigger point. And that just says like, okay, we've got long-term adaptation here.
So talk to me about the notion of trigger point injections, corticosteroid injections, you know, needling. Just people that are watching might go, oh yeah, I had a trigger point once and the doctor did X. And what could be done alternatively, or as this conservative care theme?
So like a big thing for conservative care, like in Maine, a lot of PTs will do dry needling. And basically the idea is you get in and you disrupt tissue just a little bit. You're not breaking up the tissue. You're just going in with like this really, really fine gauge needle and you're getting into the muscle fiber and you're just causing it to stop its kind of low-lying contraction. You can affect spindle fibers doing a lot of this stuff, but the idea is just to break a cycle that might be getting perpetuated. So if you have a trigger point or you have a tender point, it means that that fiber is just always on, even when it shouldn't be. So it's on when it should be, great, we use it, but then it doesn't shut off. It's really tough to get things to actually shut down when they're under tension all the time.
Well, think about the same like sleep, right? People shutting down their mind when they've got a tense day. It's similar like in the muscle.
Yeah, and you can't use willpower to get yourself to sleep either.
Right.
It's like you have to use this really roundabout way of creating a routine, counting sheep, doing all that other stuff. So some people use those types of therapies as like a very precise way of getting to it. Some of the stuff we've been playing around with is a lot more bare bones, like just ischemic compression. So once you get on the trigger point, you just compress it. A little bit of strain counter strain stuff where you get on it, you change the length of spindle fiber, see if that can down-regulate what's talking to the tissue. A lot of it though is just the idea of retraining how you walk and making sure that you're not fighting through any barriers that might be there.
And the orthotics that you had me, I would love to talk about those.
Oh yeah, the A-lines, I like them. They last.
So
that's the big thing about
there's
them.
a lot of different type of like products, and you know, podiatrists will make custom orthotics, but the need for them or the utilization of them is, I think, minimized in orthopedic issues. Like, you know, I've got a knee issue, and of course I'm an amputee, and I've got this maladaptive walking issue, and nobody has suggested along this way that an insole would be helpful for my condition until you came along and you mentioned it. And it's really done such a good job at allowing me to shim my foot into more of that outer rotation so that it can set me up for appropriate alignment from the ground as I strike my heel each step all the way up, which has helped my back, it's helped my hip. So folks that are out there that are having any kind of movement-based condition, really consider the tremendous amount of force that we put through our feet every day and the need for those feet to have a little bit of support, right?
Yep. And I mean, evolutionarily, you're made to walk around barefoot for like at least the early parts of your life when, you know, dad wasn't going to go out, kill a deer, make a size 3 pair of shoes that you're going to outgrow in 2 weeks and then put those on you. Like you're not made to be boxed into shoes like we are now. Now, if you have foot problems, having well-made shoes that box you in the right way is fantastic. But it's kind of one of those things where, you know, we've taken the poison pill and now we're here. So being able to supplement a lot of strength with good orthotics is super, super helpful. One of the things that we were looking at early on was just kind of the flattening of this arch here. And I really like the A-lines because they have that anterior transverse arch in them. It's kind of tough to find orthotics that are rigid enough through that anterior arch to really get a good effect on toe off. You have 3 arches in your feet. Turns out we have 3 for a reason. They're probably all important. So I like them for that. I've had my own foot issues. I've used them. I have one pair that's lasted me 5 years, and I I beat the hell out of them. Like I kick things, stomp things, and they don't break. So
as you're talking too, it looks probably not as impressive as it feels to the viewers, because the rotational effect of some of the modalities you're doing with some of the joint movements and the tension I feel internally, I'm sure can't be appreciated from the view of what you're doing.
Yeah,
right?
it doesn't look like we're doing too much, but basically all we're doing is we just keep taking the tissue in the calf and we're just working it through what you'd call like a medial glide. And I just pin it after I move it, so that way you don't lose your place basically. And then we work through a little bit of motion. So because your heel bone's tipped in, I pull everything down, and then once we're there, I get it pinned, I tip it the opposite way, and then we work through a little bit of motion.
Yeah.
Because when your knee moves, your foot's supposed to be able to move with it. There's supposed to be coupled motions. It's a mitered joint down there, but also there's a lot of joints inside your foot that are made to conform to an uneven ground and then transmit force evenly from the uneven ground through the knee to the hip, and then you move along to your next step. We lose that pretty easy because we sit on chairs all day. Our feet only get conditioned in like little bouts of like, okay, launch myself 10 feet in the air. Now I'm done. Now I'm going to go study for 3,000 hours this week. Needless to say that's not what that machine was designed to do. So we might need to bring it to a repair shop every so often just to try to get those aftermarket mods integrated a little bit better.
I like how you use that.
And so instead of looking at those big primary motions, yeah, we did that with that little bit of an ankle glide and we spent some time there early on. But that's the horse stuff. That's the hoof beats. We hear a horse, we do this glide, you're all better, come back when you have another issue. But, well, your issue's much more complicated. So we're going to look at all the other things that are complicated, hard to see, and really tough to notice, especially rotation. People don't perceive volumes very well. We also don't perceive rotational motion very well, but it's really important because when you're walking around, you spend a lot of time staying on one foot. Most of your gait cycle happens on one foot, and then never mind when you run. So I'm gonna run, I'm gonna jump, I'm gonna bound, I'm gonna change direction. I'm landing with 3, perhaps more times my body weight. I think when you're like in a full sprint, it's like 5 to 10 times.
I think in gymnastics, it's like 8 to 10. So
yeah,
it's gotta
on
be a
one
lot.
foot. And so every time you land on one foot though, like your center of mass isn't totally centered over that. There's a lot of things that want to spin and collapse, and turns out we don't have a lot of strengthening modalities that do really well with that. So I'm going to do a squat. Great, that's 2 foot. Okay, I'm going to do a box jump. Great, that's 2 foot. That was one of the things that I think some people on the internet, there's like this one moment where there were a bunch of internet trolls kind of getting on CrossFit because, they don't do single leg motion enough. I don't think it went anywhere. I think they just got their likes for the day and then moved along. But that's come in here as like a lot of the defining premise because of that t-shirt analogy. If I just keep winding and I put torque on the deeper internal structures, something's not going to be right by the end. Is it a vessel that's catching the brunt of that torque? Is it just the deeper fibers that are catching it? Do I move and my superficial fibers get plenty of blood flow, but then the deep ones get this ischemic compression? Now they can't do the posture. Who knows? But what we do know is there's a big pattern to it, and we should just go ahead and work in opposition to the pattern that appears to be like deeply ingrained in how your foot hits the ground. And then look up chain at the hip too. And we found like glute med and glute min were not as strong as
min for sure,
expect.
right?
Yeah.
They're both min.
Yeah.
No, it's fascinating. Honestly, I've learned so much in working with you and talking through some of these things, aside from the hope, of course, and the palliation of symptoms that it's helping to provide, just the relearning my body and also becoming more aware of things on a small level. I think a lot of us go through life every day and we've got discomfort here, or we've got this funny hiccup, or this like hitch in our giddy up when we're walking, and we just assume that that's kind of how it is, and we don't stop as often as kids do to go, but why? But why? And as a brand new mom, I can appreciate that, like, I'm going to have to get a lot slower to appreciate all of the whys and to slow things down to make it understandable for my son. And inherently, I have to do that for myself. And it's a good lesson to relearn, because I think that the pace of our life, we're always so busy moving, going, doing, being, or moving, doing, going, that we're not as concentrated on being and being aware of what's actually happening within us and to us, and the pieces of that we can control. And sometimes it takes an external factor like you, manually and also just cerebrally, to go, all right, let's challenge this.
Yeah.
And of course the assistance is helpful. So, if anybody's observing this treatment, and man, it's amazing what's being done, and just the symptomatic relief while he's doing some of these torque positions is amazing. But if you're somebody that has a disability that's watching this, and you find yourself in this pickle of a situation and you need help with your mobility or your maybe just your case, you want to bounce something off someone, make sure that you reach out to Leslie Moore-Hart and go to the Disability Assistance Forum, because we can try to help at least troubleshoot it, or at least direct you to challenge the set of constructs that you have in place right now, because you shouldn't have to suffer. And I didn't know that a Kyle existed, and I'm sure there's Kyles around. We just need to find them, and we can help you identify hopefully some folks that can try to look outside the box a bit more and be a little bit more enthusiastic to take on some of these more challenging cases. So you're not alone, and there is hope. And, my situation is just one of so many where with the right assistance, the right brains on board, the right enthusiasm, and the right timing, you can attack this conservative care approach in a way that is meaningful and actually has good outcomes. We're still in the process of determining what the longevity of these modalities will be, but I'm really optimistic, and I think that the results so far have been pretty favorable.
Yeah.
And just the opportunity to nerd out, geek out, and possibly, make this sort of protocol or circumstance that could help other people, that translates into other diagnoses, is really exciting. It's really exciting for me, being, of course, a philanthropist at heart, but the nature of what you're doing and the concept and the way you've thought through this is just so refreshing. I want to let the folks and the viewers go for now, but we will definitely be jumping back on some future segments, and I'm going to let Kyle continue to work his magic on my leg here for a bit. Is there anything that you wanted to leave the audience with before we wrap up the segment that you either want to impress upon them or something of particular importance? I just wanted to give you the opportunity to kind of make a lasting or last statement.
For a lot of it's just go out and try new things. Like, that's true for almost every aspect of your life. And so, like, I was hesitant to contact you because I'm like, oh, she's probably off being busy, doing better things. What do I know? I've never looked at this type of stuff before. I'm still just getting oriented towards which way is up in the PT field. But having had a conversation before opens a lot of doors. And so I was like, I'll try. Why not? I'll shoot her a text, see how she's doing. Worst thing that happens, we get some good food. Best thing that happens is, maybe we discover something new. And with a lot of it, just being able to play around, as a clinician, because I have a previous relationship with you, it makes me more comfortable being like, okay, let's explore this issue. Being very forward that, hey, I don't know what any of this is, like, for like the level of precision that you figure it would require as what you'd had before. I'm not that, but I'm willing to hang out, chit chat. We'll try different things. I'll look up something on this resource or that one, and we'll implement it. That willingness to try on your part and that willingness to try on my part basically allowed us to find something that is a better alternative conservative care option for your case. You'll be hard pressed just to walk into a place and find that. But if you can walk into a place and have a good conversation with whoever's running it or one of the staff there, well, explore it a little bit. If it pans out, great. If not, just try something else. Most of life is serendipitous. Most discoveries and invention have been serendipitous. So you don't really know until you stumble into the situation. You go, oh, wow, this works for me. Like, me as someone that's moving into the PT field and the PT profession, I'm like, wow, this is something I didn't know was there. And then same for you. You had tried the conventional way of managing this. You'd never think that, some conservative care options would pan out as well as they have so far. Like, I was very guarded, and I'm really happy with where we are. But if there wasn't the willingness to try out the gate from either party, then you're stuck right where you are. And at the end of the day, you need to have outcomes that are positive and outcomes that matter. Because if you don't, then, you're handicapping the profession, and you don't really want to do that. You really want to see people go out, and you want to see people flourish. So.
Awesome, man. Well, remember, go out, try new things, and really work on finding more people in your life that admit that they don't know things, but are at least willing to try. But thank you again, Kyle, for everything. I'm really excited that folks learned from you, and I'm excited to continue our therapy session here. And also, guys, until next time, best foot forward.